Hello there, and happy Friday. So excited to join you today from our Torrance studio here. It's been really fun to be in the clinic in the midst of a lot of functional neurologic disorder um, treatment happening at our clinic. And it's one of the reasons that I immerse myself in this part of the literature and just want to share it so much because this is something that we do all of the time here at Re+active. So my name's Julie Hirschberg. I'm the owner founder of Re+active Therapy and Wellness in the Los Angeles area. And today we're talking functional neurologic disorders, what every healthcare provider should know. This is part two for me. On Wednesday, I chatted on our Instagram channel and shared a lot about this great article. So it's a practical review of functional neurologic disorder for the general physician. And this just came out in 2021, published in Clinical Medicine. And Karina Bennett's the lead author, but it's from that great group in the UK, including John Stone. Talking about really, if it's for the general physician, this is for the general therapist, for the general practitioner to know some basics on functional neurologic disorder so that you can get it right and you can help people right away. I think one of the biggest frustrations that a lot of people with functional neurologic disorder have, and that I have, is that when people see me, I'm often the first, maybe second person that's even heard of functional neurologic disorder. And they've been through multiple healthcare providers, PTs, OTs, psychologists, physicians, neurologists, and nobody has really understood the disorder. Nobody's really explained it well to the person. And in fact, they may have done some damage by saying this is really in your head. We don't know what's going on. It's a psychological disorder, it's anxiety, it's this and that. And unfortunately, can really be detrimental for a person. So, I've talked about functional neurologic disorders a lot in our videos because it's one of my passions, but also there's a lot coming out in the literature like this really great review. So today, what we're going to talk about, particularly from this paper, is those things that every healthcare provider should know, particularly for the pathophysiology, what we understand of the mechanisms of this, and for treatment. So we're going to talk about those two, highlight some of the things from the article, and I'll remind you that every Friday, I send out all the videos that we've done from the week, the links to articles, resources. This Friday is a big one. I'm going to send out a bunch of our functional movement disorder, functional neurologic disorder resources. So if you're part of our education email list, it's reactiveeducation.com/newsletter. Every Friday, you'll get a summary from me. So if you're not a part of that already, I would love for you to be a part of that and get what we put together every week. A lot of it about functional neurologic disorders. So let's start off. If you're totally new to functional neurologic disorders, let's go define a few things. And I really love a good definition in the paper. So a functional neurologic disorder, so FND, it in this paper defined here is motor and sensory symptoms such as paralysis, tremor, seizures that are experienced, and they're related to a functional, meaning connection issue, versus a structural issue in the nervous system. So really nice, simple definition. Functional neurologic disorders umbrella term, there's several things that fall under that umbrella. 3PD, so a functional dizziness, falls under that umbrella. CRPS, or complex regional pain syndrome, falls under that umbrella. Functional movement disorder falls under that umbrella. That's typically, as physical therapists and occupational therapists, what we see a lot. And a functional movement disorder is characterized by involuntary but learned movement patterns that are driven by an abnormal self-directed attention. These are things that can show up as tremor, dystonia, paralysis. Those are the most common things that we see. It could be an intermittent paralysis. I've been seeing a lot of that lately. And this is a functional movement disorder. Now, that's just to get you the definition. Really important. On Wednesday, you should catch our Wednesday video. I talked a little bit about how common this is. It's very common. And we talked a little bit about the diagnosis. So today I want to talk about the understanding of the mechanisms. And there has really been a long history of functional neurologic disorders. That a lot has happened though in even the last 10 to 20 years of furthering our understanding, and a lot of that comes from improved testing and imaging to show the different mechanisms. Now, way back when, so even when I was in PT school, when I learned about some of these disorders, maybe they were called conversion disorder or even hysteria or a somatoform disorder, and that has really changed. So it's much better understood now that this is not a purely psychological or psychiatric disorder, but it's a brain network disorder. And I love that. That's a term that they use in this paper as well. So a brain network disorder. And study after study have shown that there are changes in activation patterns in different parts of the brain. So temporoparietal junction is one of those areas that has a less activation. This is a key area for our self-agency, and it's an important part of that network. So that gets us back down to the definition of a disorder where you don't have agency, don't have voluntary control of the movement. Well, turns out there's an area of your brain that controls that, and they've found less activation in that area. There also have been studies that have found those brain network issues with other areas. So supplementary motor areas in the brain, the cerebellum are other areas that have been implicated. And what's really important, and I like to point this out a lot to the people that I'm working with, is this is very different than the brain networks that are activated if you were pretending to be paralyzed or pretending to have a tremor. So if you ask somebody and they're in a functional MRI imaging and you ask them to pretend to have paralysis or pretend to have a tremor, that looks very different on imaging and in the brain than a functional neurologic disorder. So it brings home the point that this is not made up, it's not pretending, it is actually a network, a very clear network dysfunction in the brain. So that's something that has evolved a lot, a lot. So, another thing that they really nicely summarize in this paper is that there is also a piece of this that we can see as a disorder of predictive processing, meaning the brain predicting what is going to occur. And in functional leg weakness, the brain actually predicts that the leg's not there, for example. And I've had people express that, like, can't feel my legs, they don't feel like they're there, they're not attached to me. And the brain actually predicts this. And even if the sensory information is coming in, the brain overrides that sensory information and predicts that the leg is not there. Now, you can imagine why this could occur, how this could occur, especially after a leg injury. This is what happened with Oliver Sacks. He has a book on called A Leg to Stand On. Very similar thing happened. He had some functional weakness after a leg injury. So there's a problem with that predictive processing in the brain. So that's another piece of the pie in the pathophysiology. That's really a motor control sensory problem. We can test it out and treat it, which is so good. So that is the next thing, the last thing that I wanted to talk about today is the treatment aspect. And as I mentioned at the beginning, many people with FND have had negative experiences in the healthcare setting. And this is why they published the paper. A lot of that comes from a combination of not really knowing or understanding a functional neurologic disorder. And look, I've been there. I didn't know and understand it before too. So I've contributed to those negative experiences in the past. Um, Not anymore, I will say. I like my clinic myself, pride myself on really diving in and really trying to understand and know this disorder. So there's a combination of not knowing, and then also I hear this again and again, is not believing or blaming or saying things like it's all in your head. So not really understanding and then really having miscommunication about what the underlying cause is. Um, so that when I talk about treatment, then having really great communication about the disorder is the first part. So, the first piece of it, and again, this is written for the general physician. So physical therapists aren't making a diagnosis, occupational therapists aren't making a diagnosis. But what's really important for the general physician is that this is a rule in diagnosis, and then you can share those positive features. Here are the findings that you have: a positive Hoover sign and treatment of tremor, for example. These rule in a functional neurologic disorder. It's not just a rule out disorder. And that part of having the diagnosis, having the positive diagnosis, is a big part of treatment. Now, we have found, and I love that they mention this in here, there are a lot of physical symptoms that coexist and contribute to functional neurologic disorders. Things that we find a lot, and they talk about this in the paper, so this is really validating: migraine, headache, nerve tension, nerve irritation like sciatica or neuralgia, rheumatological issues, so especially joint hypermobility. This is something we see a lot. Ehlers-Danlos, these are very common comorbidities with a functional neurologic disorder, and they're part of the pieces of the puzzle. So you've got to look into those as well. I really love working with our team because we have specialists in the hypermobility syndromes and Ehlers-Danlos and rheumatology, and so we can really work together to treat that as well as a functional neurologic disorder, because it's often a trigger. So I love that this article talked about it. Yesterday, or not yesterday, I'm sorry, Wednesday in my Instagram live, I talked about the physical therapy approach a little bit, and in particular, how a traditional approach really doesn't work. If you, in traditional mode of therapy, are bringing a lot of attention to muscle activation and to the body, it actually can be very counterproductive and make things worse. So that's one tidbit, very, very important. But something else that I wanted to really share is that there's also research that shows the opposite of that traditional approach. So more of an approach that unlocks automatic movements is highly effective. So there was a pilot trial of 60 patients. They had symptoms for over 5 years. They did a 1 week intensive in this. They had 72% improvement in the intervention group, and only 28% improvement in a group receiving kind of a standard of care therapy. So really promising results with specialized physical therapy and occupational therapy as well. So last but not least, I want to talk about the psychiatry, psychology perspective that they also talk in here. And one of the things that they talk about in this article is that, again, this is not just conversion disorder. So this is not just neurologic and physical symptoms coming from a purely psychological cause. However, you can imagine if you lose voluntary control, if you have intermittent paralysis, if you're having tremor, it's extremely stressful and it can cause anxiety. And also, that anxiety and panic and even post traumatic stress can also contribute to the symptoms. So, we can have kind of a spiral there, not always know chicken or the egg which came first, but treating is really, really important. We have an amazing psychology team and a neuropsychologist that understands functional neurologic disorder. And again, the evidence is pretty strong here for doing a neuropsychology or psychology program that's specific for FND, and includes things like cognitive behavioral therapy, but truly a holistic approach for a person, is a key component of treatment because we cannot separate like mind, brain, body. We really have to interconnect it. And that is precisely why we run an interdisciplinary program: physical therapy, occupational therapy, psychology, yoga therapy for the autonomic influence as well. And what's really great is the research, this review supports very strongly that approach, and that there's hope. People can have really full recovery in that approach. And to me, hope is a big part of it. So there you had it. We talked about some of the basics that every healthcare provider should know about FND: what it is, what's the understanding and the pathophysiology behind it, and then how we might go about treatment for it, from a multifaceted level. So I hope you found that helpful. And I also really hope that you can share it with other healthcare providers. Really get the word out about what FND is and how we can understand it from a brain perspective and treat it. I think that's so important. So share it and join our newsletter. So again, it's reactiveeducation.com/newsletter. If you're a healthcare professional, every Friday, I'm sending out all of our resources. This article is coming to you today, and all of our videos. So join our newsletter. We'll send that out every week. And thank you so much for joining me on a weekly basis. I'm going to be camping next week. I won't see you next week, but I will see you the following week. And I really look forward to hearing your questions and your thoughts and what you're learning about all of these disorders as well. So thanks again and have a wonderful day, a wonderful weekend.